Good evening, and thank you, our dear guests, Professor Bruce Lassie, Professor Silvia Vannuccini, and Professor Abha, and our dear colleagues, Professor Ashraf Kurtan, Professor Gabriel, and Professor Mahdi, for being with us. Thank you, IT, for the extreme effort that you're doing. And of course, we thank IPSA also for their continuous support of the scientific activity of EFRE. Today we have a busy webinar, so I will just go right ahead with the presentation. And my presentation is about endometrioma as an endless dilemma. Endometriosis generally is classified into 4 types, and our talk today is about endometrioma. The classic picture of endometrioma is a circumscribed cyst with homogeneous ground glass appearance and thick wall. But endometrioma is a heterogeneous spectrum of disorders. You cannot speak about one endometrioma. The origin is different, genomic alterations are different, lining of endometrioma varies, so it is occupied by endometrioid tissue, in some cases 10%, some others 90%. Ultrasound images varies also, and associated peritoneal and deep endometriosis also, the incidence varies in different types of endometrioma. So we cannot speak about one endometrioma. As you can see here in this ultrasound picture, this is a classic endometrioma. The wall is thick and homogeneous ground glass appearance. The second is again thick wall with slight vascularity and heterogeneous content. The third is has a protruding polyp without vasculature, and the fourth is the suspicious one with a polyp that has vasculature in it. So when we speak about endometrioma, we have to be careful. Which endometrioma are we speaking about? In fact, basic research, and I cannot speak about basic research in the presence of Bruce Lassie, my mentor and friend and teacher, but the basic research indicates a potential mediated damage to the ovary induced by endometrioma. This is basic research. This damage originates from changes in the endometrioid tissue surrounding the endometrioma, with the resultant accumulation of toxic material and iron and other metalloproteinases inside the cyst. And because the cyst wall is thin, this content may leak to the ovary and induces specifically fibrosis in the cortical tissue of the ovary. The stroma is affected, and when the stroma is affected, folliculogenesis is not appropriate. It increases in number and it decreases in quality. The hallmark of the basic research studies is the increased reactive oxygen species that results in cortical fibrosis, as we've mentioned. But also the presence of an endometrioma in the ovary carries the risk of infection, of follicular fluid contamination, and possibility of complication during pregnancy and possibility of cancer development. So yes, there is basic research indicating that there is damage, but also there is a clinical risk, although the incidence is low. So we have to weigh the risk of untreated endometrioma versus the risk of surgical treatment of endometrioma. This is basic research, but clinical story is different. Because clinically, endometrioma per se do not result in lower AMH values. They don't affect ovarian reserve. This is clinical. And endometrioma are not associated with infertility. They are not a risk factor for infertility. Endometriosis, yes, but endometrioma does not increase the risk of infertility. And I think 3 years ago, Professor Bruce Lassie, he published this nice debate. I advise you to read this paper. I spent 3 days reading it to be able to argue with him. And in this, Bruce was pro-surgery in endometrioma. And of course, there is other scientists who were also either with or against surgery in endometrioma. As regards the meta-analysis or the evidence, surgical management of endometrioma does not improve pregnancy rate. It doesn't increase the total number of embryos available. It does not increase the total number of embryos available. Also, it does not improve live birth rate in endometrioma patients. So surgery does not improve outcome of ICSI. But surgery could have indications: rapid growth, suspicious features, painful symptoms that are not relieved by medications, and of course, the theoretical risk of potential for rupture in pregnancy, inability to access follicles, etc. There is no big argument with surgery, but of course, endometrioma is a place for individualized treatment, individualized patient care. And if you choose to go with surgery, which one would you do, ablation or extirpation or stripping of the cyst wall? All the outcome, pain and pregnancy, are better with the stripping of the cyst. Ablation results in more pain, more recurrence, and less pregnancy. But after stripping, the rate of spontaneous ovulation is lower in the operated ovary. Ovarian reserve decreases, and responsiveness to ovarian hyperstimulation during ICSI also is reduced. So if you want surgery, you have to do extirpation of the wall. And if you do extirpation of the wall, then you will end up with problems. So the decision to remove or leave the endometrioma should be carefully considered. There is high risk of recurrence after surgery. The results are significantly lower after repetitive surgery. Endometrioma surgery before IVF does not increase fertility, and the risk of conservative management, of course, infection, follicular fluid contamination, pregnancy complication, and cancer development have to be weighed and understood in terms of prevalence to be able to make a decision. In women operated for bilateral endometrioma, there is a risk, of course, of more diminishing of ovarian reserve, although the data does not support this idea. So based on the evidence reviewed, it can be concluded that conservative management may actually expose women to four of the following theoretical risks: infection, follicular fluid contamination, high risk of pregnancy, and cancer. The first three are very low incidence, and the number needed to treat is very low. So this is another argument against surgery. So we are apparently in an era of conservative management of endometrioma, and it is suggested that endometrioma with a mean diameter below 4 centimeters should not be systematically removed, and this is the recommendation of SRM and ESH. I have this case, and I'm sorry, it seems that the video is not working, but it is a case of bilateral chocolate cyst, obliteration of Douglas pouch, and sliding test is negative, and the patient is 37 years, primary infertility 6 years, AMH is 1.8, and no previous surgery and no previous IVF, kissing ovaries, and obliteration of Douglas pouch. So should we do surgery? Should we do surgery then IVF? Should we do IVF directly or any further workup? So let us start with Professor Bruce Lassie. Can you open for Professor Bruce Lassie? Bruce, please.
Yes. So
which line of management would you choose for this case?
I like a choice that includes doing IVF first to make your embryos, and then going back and taking care of the endometriomas if she does not get pregnant or has implantation defects that I'll describe.
Of course. If you do this, would you be afraid that this will affect the ovarian reserve markedly in such a patient, so that she will not have a chance again to be pregnant if she become pregnant in the first IVF?
You can always do a second IVF and try to get enough embryos so that surgery then is not such a risk. But yeah, this is a difficult case, as you. It
is, yes. It is. Professor Abha? افتح الأبهى.
So,
what would you do for this patient?
I would agree that I would do IVF first, looking at she's 37-year-old. You've got low AMH. So your ovarian reserve is already affected. If you can reach the ovaries transvaginally, get the eggs out at least, and then save them first. So I would do IVF first, absolutely.
Professor Sylvia?
Can you hear me?
Yes, of course.
Absolutely,
what
I
would
agree.
You do for this?
I absolutely agree for conservative management, not doing
IVF
surgery.
First.
Yeah.
So you would do IVF
first.
IVF.
Yeah, I prefer. I think it's the best choice to manage properly the patient and give her the best chance to get pregnant, actually.
Would you do IVF with long suppression, 3-month suppression, or just long protocol, or antagonist and freeze all? Bruce?
I would be concerned with this low AMH that long suppression would yield very few eggs. So I would not do that.
Would you freeze all or just go with fresh transfer?
I would freeze all.
And when you go for a transfer, would you do suppression before the transfer?
Yes.
Excellent, excellent. Professor Abha?
Muted. Yeah, wait for my presentation for that. I suppose for the stimulation. It depends on lots of things, but as you say, the AMH is low, so long down regulation will further suppress. So I wouldn't go for long down regulation here. We collect the eggs, see what the embryo quality is and everything else before we decide to do further. So it'll be very much individualized based on her symptoms or other cases. So.
Yes, of course. Professor Sylvia?
Can you hear me? I would
yes.
Look very properly to the uterus. So it would really be the topic of my presentation, but I think that the solution is in the uterus. So I hope to give information more properly about the myometrium, which is very, very important, not just the ovaries to take account here.
This brings us to this question, and we start with you, Sylvia. There is a possibility of high possibility of deep endometriosis in this patient. Would it make a difference in management?
Well, it's the association is very high. So I talk about my personal experience as I'm doing lots of ultrasound scan. So when I find an endometrioma, it's very important to look for deep lesions. And in a very high percentage of cases, we can find them. Maybe they are very small. We can find in the ligaments, in the uterosacral ligaments or the torus. But usually if we really do a mapping of the pelvis, we can find something. So just to make sure that we have all the information, of course, I'm more in the part of the pre-IVF staging of the patient rather than the IVF technique from my point of view. But to give the proper information to IVF people, let's say like that, it's very important to know the whole picture, not just how is the MIH or how many endometrioma, how many follicles we have, but also which is the situation in the pelvis.
That's very good. Professor Lessie?
Well, I will get to this in my talk, but some women with endometriosis are not going to be impacted by their disease and others are. And we need a way to define which group they belong to.
Yeah, okay. So the second case is unilateral endometrioma, 31 years, 2 years infertility, normal male, AMH 2.6, pelvic pain, responsive to medical treatment. She's coming for infertility. Would you give her medical treatment or surgery or IVF? Professor Lessie.
The pain issue allows you to operate on these patients according to ASRM guidelines, but since she's coming for infertility and her AMH is not exceedingly high, I would feel more comfortable making embryos and doing a freeze-all cycle first, as we did or suggested in the last patient, before operating on the patient.
That's very good. Professor Abha?
I would agree with that, I wouldn't operate on this size, and it doesn't seem very big to me, and her AMH is already low. She's got 2 years of infertility, pain is responding, so we carry on with IVF, create the embryos, and then we take it from there, depending upon whether we do freeze-all or fresh transfer.
Professor Sylvia?
I think we all agree that's the best strategy. Yeah, all agree, no surgery.
Okay, Professor Kortam? Ashraf?
Yes, I do agree. This size is not to be operated upon as surgery. We can proceed directly to IVF, provided that there is an access to pick up the oocytes from the ovary. We proceed to this one. And there is a debate here whether to transfer freshly or to freeze all. I would transfer the embryos fresh transfer.
Professor Gabriel?
Yes, can you hear me? Well, what I will do is I will explore the tube's patency. If she hasn't had the hysterosalpingogram with Lividol, I will do for this and then wait for the therapeutic effect of it. I will also explore whether the patient is able to wait for 6 or 9 months to see the effect of laparoscopy or not. Otherwise, I will go for IVF directly.
Professor Mahdi?
Good evening. As regards this case, if fallopian tubes is patent, both tubes patent, or at least one tube is patent, I can give her a chance for 6 months of controlled ovarian stimulation with or without IOI. If no pregnancy, go ahead for IVF and the fresh transfer.
Thank you very much. Thank you very much. So in fact, a balanced and shared approach with women taking into consideration all the pros and cons of surgery is currently recommended. And the retrieval of oocytes sometimes may be difficult. There is a risk of infection if surgery is done or with IVF, and there is a risk of hidden malignancy that should be considered in management of patients, of course. But there are no studies to say exactly what is the prevalence of these problems, especially infection and the risk of malignancy. So the first category of patients consists of women presenting with endometrioma and related infertility, and we have discussed this. And the second category of patients consists of women presenting with endometrioma with pelvic pain without infertility, and Professor Kortam will discuss this. And lastly, the third category of patients consists of women presenting with endometrioma-related infertility and pelvic pain, and you've discussed this very clearly. And it is clearly that endometrioma is a place for individualized patient care that depends on proper characterization of the region and proper characterization of the patient also. And thank you very much.